Welcome, everyone, and thank you for joining us. I'm Melissa Warner, Executive Vice President at HealthCom Media, publisher of Wound Care Advisor, American Nurse Today, and several other healthcare-related websites and journals. I'll be serving as your moderator today. Our topic today is Innovations in Wound Care, the role of wound cleansing in the management of wounds. Our presenter today is Martha Kelso, founder and CEO of Wound Care Plus. As a visionary and entrepreneur in the field of mobile medicine, she has operated mobile wound care practices nationwide for many years. Martha educates on the art and science of wound healing and how practical solutions apply to healthcare professionals today. She started her career as a certified nurse aide at the age of 15 in Kansas, before moving to Kansas City, Missouri to attend nursing school. Long-term care nursing was her first love and her biggest challenge. We welcome Martha today and thank her for her time and valuable information. This educational program is brought to you by Angelini Pharma, offering innovative solutions to promote infection control, antisepsis, disinfection, and wound healing. We thank them for their support.
Melissa, thank you so much for that wonderful introduction. I'd also like to thank Wound Care Advisor and Angelini for hosting this really important webinar about wound cleansing, the wound microenvironment, and we want to make sure that we meet the objectives for today. So let's review the objectives before we really get into the meat of the presentation. By the end of this webinar, we want the learner to be able to identify the role of proper wound cleansing. We want to discuss how to select and use non-toxic wound cleansers. Very, very important. We're also going to review the wound microenvironment. We want to make sure that your wound cleansing practice is up to date by the cleansing and its role, basic cleansing techniques, and when not to clean a wound. We're going to review the ideal wound cleanser, the use of hypochlorous acid as a wound cleanser, and clinical case studies. There'll be some photos involved. So let's get started with the wound microenvironment. Wound microenvironment of chronic wounds represents a major therapeutic challenge to clinicians across the United States. We have a lot of relevant factors that influence the healing process. This can be everything from bacteria to proteases, biofilm, and oxygen. So let's review those individually. In the chronic wound, that chronic wound provides an ideal environment for bacterial growth. And of course, bacterial growth can turn into bacterial infection, which is one of the most prevalent causes for poor wound healing or prevention of wound healing. Proteases such as MMPs and elastase play such a key role in wound healing, but excessive expression can lead to prolonged inflammation and delayed wound healing. It can absolutely cause a wound to stall out and prevent wound healing or delayed wound healing. With biofilm, that's bacterial biofilm that plays an important role in maintaining prolonged inflammation that can ultimately lead to the failure of wound healing. Of course, we want to get a wound out of the cycle of inflammation so we can get that wound into a cycle of healing. Oxygen in chronic wounds must have oxygen present in order for a wound to heal. So in chronic wounds, there's a substantial imbalance between the supply of oxygen and the high energy demand of the healing tissue. Inadequate oxygenation can slow down wound healing processes. We must have oxygenation to keep tissue healthy and tissue healing. Let's talk about the importance of pH in wound healing. So here we have the pH all the way from the acidic to the alkaline. And what we've known over the years through research and science is wounds with an alkaline pH have demonstrated lower rates of healing. Healthy skin needs to have a slightly acidic pH, usually a pH of about 5. With our wound cleansing, the pH is important. We need to know the product that we're putting into the wound, if it's helping balance the pH into a healthy wound healing environment, or if it's skewing the pH of a wound, or even the skin, creating more issues. The pH of a chronic wound is mainly alkaline. So anything at an 8 or above is going to stall out wound healing. We really want that therapeutic range. We've got to pay attention to our wound cleansers and how it impacts the pH of our wound and skin. So let's review that. The importance of acidic pH is an acidic environment in a wound bed is an additional benefit that can contribute to the reboot of the wound towards healing, really pushing that wound out of the chronic or inflammation stage into a healing stage. An acidic pH can contribute to an unsuitable environment for the growth of pathogenic bacteria. Of course, reduction of bacteria helps prevent infection. Preventing infection, of course, helps keep wounds healing. A more acidic environment can reduce the activity of MMPs, proteases, and restore the healing state. An acidic environment can reduce the growth rate of bacterial load and biofilm. And of course, our acidic pH can improve tissue oxygenation, which is an essential condition for successful wound healing. So we have 4 items: bacteria, proteases, biofilms, and oxygen, that all relate back to the acidity of pH in a wound bed. And that leads us to asking the question, is your wound cleansing practice up to date? Cleansing and its role. Wound cleansing, of course, we've done for centuries. We've done that to remove surface contaminants, of course, bacteria, non-viable tissue, and excess exudates. Too much drainage is harmful to tissue and the surrounding skin. Wound cleansing can be such an effective way to remove inflammatory stimulants and local barriers from the wound bed. It's kind of our first line of defense to get started on healing a wound. So an ideal wound cleanser needs to modulate the wound microenvironment. We've got to balance the management of key components with preservation of tissue safety. We've got to make sure when we are choosing a wound cleansing regimen that it is not cytotoxic to the wound or other cells. So basic cleansing techniques, of course, there's swabbing. We use items that don't leave debris in the wound bed. And then, of course, irrigation. Irrigation is where we are using some form of pressure or force behind the fluid, the irrigation fluid, to try to remove debris. It also rinses bacteria out of the wound. Of course, we don't want to clean a wound when they are dry, gangrenous, where the body is demarcating or self-amputating. Our goal in those cases are to keep the wound clean and dry. We don't want to rinse, we don't want to hydrate, we don't want a moist wound healing environment, because we will convert dry gangrene to wet gangrene. And then, of course, wet gangrene spreads. Anytime we have fragile granulation tissue, if we are cleansing too aggressively, we can absolutely damage that fragile granulation tissue. It can be traumatic. It can cause excessive bleeding that's unnecessary. It can increase pain. So in these 2 instances, we absolutely would not want to aggressively clean a wound. But that brings us to the ideal wound cleanser. The ideal wound cleanser is not cytotoxic. So when you ask your patient about their basic wound care regimens at home, the usual and in some cases unfortunate answer is cytotoxic ingredients, such as hydrogen peroxide or alcohol. Or we're using topical Neosporin first aid cream, but we're not sure why we're using it. And of course, topical creams can harbor bacteria or even fungus. We're creating a dark, warm, moist wound healing environment where fungus can proliferate. So when we talk about antiseptics, such as hydrogen peroxide or alcohol, we know that research has shown these antiseptics have a negative impact on healing wounds. Antiseptics can include alcohol, iodine, chlorhexidine gluconate, silver, or hydrogen peroxide. These are known cytotoxic ingredients that do not help the wound heal. Antiseptics can be used in right situations and durations, but we need to know it's for an extremely limited amount of time, and we need to know what our goal is before we start reaching for cytotoxic products instead of non-cytotoxic products. When we look at the ideal wound cleanser, we are looking for several broad categories of solutions, right? So there's hypochlorous acid. We know this is produced by the body's immune cells in response to invading pathogens. When used as a wound cleanser ingredient, it acts as a preservative by inhibiting growth of microorganisms within the solution. Different hypochlorous acids we know have a 12-second to 15-second kill time for certain bacteria, viruses, etc. It's a good option that's non-cytotoxic and encourages appropriate pH and wound healing. Saline solution generally does not contain preservatives, so bacterial growth can occur once it's exposed to opportunistic organisms. Sodium hypochlorite is familiar to healthcare practitioners as Dakin's solution. Dakin's solution can be injurious to the wound tissue and can slow down wound healing. Dakin's solution is known as a cytotoxic product that's often used for wound irrigation or sometimes even used to be left in the wound. Again, cytotoxic ingredients are the ones that we do not want to reach for first or for prolonged situations. We want our wound cleansing regimen to help achieve the goals of wound bed preparation by removing microorganisms, biological, and environmental debris. Characteristics of an ideal wound cleanser: it needs to be non-cytotoxic to tissue. The ideal wound cleanser should decrease colonization of the wound bed. It needs to be cost-effective and stable. If it is not stable after 24 hours of opening, it's not cost-effective. We want to look for that longer shelf time, but also longer usability once it's opened. The ideal wound cleanser should not be an alkaline pH. Hypochlorous acid as a wound cleanser is an ideal solution. Let's talk about why. Hypochlorous acid is one of the major inorganic bactericidal compounds of innate immunity, and it is effective against a broad range of microorganisms. Although they look similar, hypochlorous acid and sodium hypochlorite are still very different. The cell wall of pathogens is negatively charged. Hypochlorous acid can easily penetrate the cell and destroy the pathogens from the inner. Sodium hypochlorite cannot easily penetrate the wall of pathogens. At the same concentration, the biocidal activity of hypochlorous acid is 80 times stronger than sodium hypochlorite. Hypochlorous acid is naturally found in our body. It's produced by the immune cells, the white blood cells, in response to invading pathogens. It's that chemical reaction that our body creates. Hypochlorous acid is 80 times stronger than sodium hypochlorite, and it creates an acidic pH. With sodium hypochlorite, also known as Dakin's solution, this can be injurious to the wound. It can be cytotoxic. We know that cytotoxicity can slow down wound healing. We also know that sodium hypochlorite does not easily penetrate the bacteria. It also creates an alkaline pH. It's not considered an ideal agent to be used as a wound cleanser. So let's review some clinical case studies. Let's look at some leg ulcers. Here we have a 48-year-old male. He's had a wound for about 15 years before treatment with a wound cleanser containing hypochlorous acid. This gentleman had a lot of severe comorbid medical conditions, including essential hypertension, lymphoma diagnosed in 1999, epilepsy, a valvular heart disease, osteomyelitis of the knee diagnosed in 2010. Before the use of Nexidine, this gentleman was in a traffic accident with the left lower limb having a severe injury. Subsequent alteration of vascular architecture with the appearance of a large ulcer on the lower third of the leg after chemotherapy due to a car accident about 15 years ago. So the large ulcer on the lower leg, not the lower third of that leg, was treated with cycles of hyperbaric oxygen. Since then, the lesion never came to resolution. From November 2011 to June 2013, the patient underwent 4 surgeries with an engineered graft and skin graft without any benefit, with the exception of wound depth becoming superficial. Okay. So we can see the extensive wound on the left-hand side before we started treating them with hypochlorous acid. On the right, you can see the significant decrease in surface area of that wound. So we can also see the time in days. Day 0, it was colonized, had extensive drainage, it was hyperexudative, had a superficial depth, and we had square centimeters of 250 square centimeters. He also rated this pain as a 7. At day 12, it was still colonized. Drainage had reduced to an average or moderate level of drainage, still superficial, square centimeters still the same, but his pain had reduced down to a 6. We're starting to show improvement out of that cycle of inflammation. At day 42, we cleaned, the tissues now look cleansed, they do not look colonized anymore. It's still superficial, and we're starting to show reduction in square centimeters. And his pain, of course, has reduced by almost 50%. At 183 days, we are now starting to show signs of reepithelialization. The exudate management is controlled, still superficial with an area of 184 square centimeters. Pain is now down to a 2. And at, of course, 302 days, he is still showing signs of healing. The drainage is well controlled, still superficial, square centimeters of 135, and his pain is at a 2, which is approximately a 46% reduction in square centimeters, overall size of the wound. More importantly, his pain has reduced by 71.4%, and we are out of that cycle of inflammation. Clinical case study number 2, we have a gentleman that's 31 years of age. 2 years before treatment with a wound cleanser containing hypochlorous acid was when this wound was developed. He has severe comorbidities, including young refractory severe obesity. He's had a sleeve gastrectomy in 2010. Pre-surgery weight was 227 kilograms, 148 kilograms after surgery in 2011. He has psoriatic arthritis, and a very large peripheral and lower edema on a lymphostatic basis. This gentleman had stasis ulcers that would not tolerate the bandage. He had grafting with improvement on June 2013, very low compliance, and constant infection. So we have our pre-photo on the left-hand side and the post-photo on the right-hand side, and that's remarkable. So on day 0, we started out with infected tissue that were hyperdraining, had a deep ulcer with a 300 square centimeters a wound, and of course an 8 pain, again showing that we're stuck in the cycle of inflammation. At day 22, we now have cleansed tissue, no longer showing infection. Drainage has reduced down to a moderate or average level. with a superficial depth and 250 square centimeters of the wound. Pain now reduced to a 5. At day 155, our area has reduced down to 180 square centimeters, and its pain has gone down to a 2. 236 days in, it's starting to drain again. Still superficial. Area has reduced by 50% down to 150 square centimeters. Pain remains at a 2. Day 295, still cleansed. Drainage is now poor, and the depth superficial with an area of 118 square centimeters. That's a reduction of approximately 60% in square centimeter reduction. We are showing healing, which is excellent. And of course, our third case study, 83-year-old male, 2.5 years before treatment with a wound cleanser containing hypochlorous acid was when this wound set in. So 2.5 years before we started using hypochlorous acid is how long this wound has existed. Again, severe comorbid medical condition. He's had BPH, benign prostatic hyperplasia with previous transurethral resection of the prostate. He's had high blood pressure, hypertension, and post-thrombotic syndrome on the right leg. He's also had chronic corrential anemia, lipotimic episodes, and paroxysmal atrial fibrillation. So in April of 2012, he was hospitalized with a diagnosis of bilateral ulcers on the lower limbs and a diagnosis of pyodermic gangrenosum and polymicromic superinfection with severe sepsis. Again, we had the proximal AFib. We put in a wandering pacemaker with heparin, coagulant dosage. He had mild heart failure and a sarcadic conditions and a severe protein caloric malnutrition. Had psychomotor agitation with delirium, perhaps related to opiate usage. Also ended up with suspected sleep apnea. In April of 2013, he's now hospitalized just a year later, and we're going in for a regraft type procedure. And some extensive comorbid medical conditions. So you can see that we started out on the left-hand side, his wounds to begin with. On the right-hand side, significant improvement just from choosing the right wound cleansing regimen. So we started out with slough, high drainage, and square centimeters of 160 square centimeters and a pain of 6. Then we ended up with the second measurements. He's got slough, he's high draining, it's superficial. He's dropped to 140 square centimeters with a pain of 6. And then at day 0 was when we introduced hypochlorous acid. So at day 190, after we introduced Nexidine into his wound cleansing regimen, you can see that he still had slough, but the drainage had reduced. Also, the square centimeters had reduced from 120 down to 70. His pain went from a 5 to a 2. So we're now showing positive improvement. We're getting him out of that cycle of inflammation. By day 275, he had slough, superficial, square centimeters sitting at 38. That is remarkable. So we have a almost 70% increase, reduction in square centimeters of the wound, and an 80% reduction in pain. Hypochlorous acid is your ideal agent for wound cleansing. It's important to add it into your regimen. It's also important to understand it helps with pH, pH of the wound, correcting the pH of the wound, reduction in bacteria load on the wound, helps increase the oxygenation of the wound, also helps reduce in pain. Now we want to take a minute to thank Angelini for sponsoring this webinar. We're going to take a few minutes to kind of review some of the information that we covered. Again, Angelini has Nexidine. Nexidine is what we're using for our ideal wound cleansing agent. So some of the product features of Nexidine that can support physiological healing process, it's FDA cleared. We're not using something that's off-label or not indicated for wound cleansing. They have FDA clearance for their hypochlorous acid-based wound cleanser. It was developed for a topical treatment in the field of acute and chronic wound management. It has that ideal pH of 2.5 to 3.0. Nexidine has high purity. It's greater than 95% of free chlorine species derived from hypochlorous acid. And we have free chlorine species of approximately 40 to 70 parts per million, so it's not cytotoxic to humans. And we talked about long stability. We want to have that long stability shelf life. This one has 30 days stability from the first time that you open it. We use that mechanical action of the fluid flowing across the lesion to help remove biologic and inert materials such as microorganisms, biological debris, and environmental dirt. We talked about the kill time assay. So pathogenic bacteria such as Staphylococcus aureus, Staphylococcus pyogenes, epidermidis, Pseudomonas, E. coli, your multi-drug resistant organisms, they all have approximately a 15-second kill time at 99% or more. That's very important when we're talking about reducing antibiotic usage and not contributing to the multi-drug resistant organism. I've authored an article discussing the use of hypochlorous acid and why it's important to help to introduce that to your regimen to reduce antibiotic usage and not contribute to the multi-drug resistant organisms as CMS is currently mandating. We want to use Nexidine on wounds because it's fast and simple. So at each treatment or medication of the wound, we want to spray the whole lesion abundantly with Nexidine. Then we want to allow that solution to dry. You don't need to rinse it. It's not cytotoxic, so it's not something that we need to remove out of the wound. We then want to use a second application of Nexidine. We can do it consecutively and repeated if necessary. Again, once you apply Nexidine, we want to allow it to dry. Once you're done letting the Nexidine dry, now you can start your wound application. Whichever dressing is currently ordered for the wound can be directly applied. When you use the right tools for all patients, all wounds, you are making all the difference in the world. We want wounds to heal. We don't want them to stall out. We don't want them to become chronic for all the reasons that we listed earlier in the presentation. When wounds heal, patients are happier, our medical malpractice is reduced, wounds heal timely, we save dollars for our insurance system. Nexidine is an obvious choice for adding that to our wound cleansing regimen. Thank you.